today I'm going to show you how to use the LifePack 12. So first thing we're going to do is we're going to check the batteries. So that's you find behind here and you push the grey buttons on here, and if they light up, they're fully charged. In the event that we would need to charge them, we take the batteries out like so and replace them with a new one. Cool. First thing we're going to do is we're going to make sure that the test load is connected. So this can be found in the back pocket, and the cable is usually stored in there. So I'm going to plug that in, place that there, and turn it on. So what we're going to do is we're going to select the energy, we enter manual mode, and we charge it to 50 joules. Yep. So I'm just going to charge it, and when you need to shock, you push shock. Yep. And if you wanted to disarm the charge, you push charge and just push that, and it disarms the shock. Next thing we're going to do is we're going to run a test. So we go to options, scroll down the dial and go to use a test. Push that there and it'll just be running a test. Okay, so it says up there that it has passed. You need to make sure on here that it says user test passed. So if we wanted to change from manual mode to AED mode, we'll just push analyze,
Analyzing now.
Change.
Stand clear.
But we don't want that, so I'll just push that off. And to change the lead sizes, we can just push the lead button and we can change to whatever we like. But we'll just have it on the fourth one down here, so it can show all the ECG. And if we want to do different sizes, we can have them to be very small, so it shows that here, or we can have them to be very large. So I'm just going to set that to 1.5. And for heart rate sounds, we'll just turn the knob until it goes up to highlighting on heart rate, push the button, push the QoS volume, and you can turn it all the way up, and turn it all the way back down. And we'll just push home screen. So in the event that we need to change the paper, we'll just pull that open, like so, take it out, and then a new one should be found in the back pocket here, like so. And we'll just place that in there. Have the paper coming out like that. And we push it in like so. And we'll just rip it off there. So, to find the ETCO2 plug, it is right here. And the SpO2 and the ECG connections are already plugged in, and they can be found inside here. The left-hand pouch contains in-date deeper pads, which are in here. We also have a plastic bag with aspirin, DTN and a razor. In the right-hand pouch, we have got a blood pressure cuff, a SpO2 probe and ECG leads. If we wanted to measure blood pressure, we'd take the blood pressure cuff out and we push the NIBP button and it will do an automatic blood pressure reading. I'm going to show you how to use an oral pharyngeal airway, commonly known as an OPA. We'll use this on our patients if they have a GCS of less than 8 or on the verbal scale less than 2. So first thing we're going to do is check the size of the OPA. So we measure this by going from mouth to mandible, and that seems the right size. So we tilt the head back so we can open the airway. We insert it following the curvature of the mouth, facing this way, and then once you're halfway through, you turn it 180 degrees and push it down. When inserting the OPA, you need to watch out for the tongue, just so as it doesn't obstruct the airway. Complications of an OPA can include obstructing the airway if your OPA is too large, and worsening the airway or damaging the oral pharynx. So next up is the nasal pharyngeal airway, also known as the NPA. First thing we're going to do is we're going to measure it from nostril to mandible, and that fits correctly. And you've got to make sure that you lubricate it with some water-based lube. Cool. So we insert it at a 90-degree angle to the face. And if there's any resistance, you twist it 180 degrees. And any more resistance, you can change nostrils. And then twist it all the way down until the flange reaches the nostril. Benefits of using the NPA is that there is no gag reflex or no induced vomiting. Reasons for using an NPA is if they cannot tolerate an OPA, if they have a clenched or locked jaw, and it can be used with a GCS above 8. Contraindications of using an NPA is if they have a basal skull fracture or if they have nasal polyps or bleeding. Next up, I'm going to show you how to deliver oxygen. So with our regulator, we're going to check the black Bodax seal. Just check there's nothing damaged to it, so there won't be any leakages with the oxygen. With our oxygen tank, we need to check that we'll be using oxygen. So on here, this is just for training, so we're just using compressed air, but in a real situation, you'll need to check that it says O2. So we'll place it on our oxygen bottle, lining up the nasal prongs, putting it on like so, turn it all the way, and then go back a quarter. Yep, so I'm just going to turn my oxygen on and check that there's enough in there, checking that there's at least 1000 psi. So we're going to lay our oxygen tank down just so it's not a danger to anyone else. So today we're going to use a acute or Hudson mask on our patient, and this delivers 60% oxygen at a flow rate of 6 to 8 litres per minute. So I'm just going to put it into my regulator, turn it on at a minimum of 6 litres per minute, and lie back down. I'm going to place it on my patient, like so. And once you feel that the patient has got enough oxygen, you will remove the mask from the patient and then turn the oxygen off, like so. Remove all the tubing, and then you'll flush out the regulator. Yeah. And then we'll just remove it like so. Next up, I'm going to demonstrate how to use the bag valve mask. So first thing I'm going to do is check the tightness and make sure no air is escaping. Yep, so it feels tight. And also we can check the reservoir, check that there's no leaking in the bag, place it at this end, and check that it fully inflates. Yeah, so there we go. Place it at the other end. We can also use the Mohs assessment for the bag valve mask. So we're going to attach it to running oxygen, and this delivers oxygen at 98 to 100% concentration and at 10 to 15 litres per minute. So we're just going to turn it on, yeah, at a minimum of 10 litres per minute. Okay, so we're going to tilt our patient's head back and place an OPA or an NPA. In this case, we'll be using an OPA. Yep. Place it in. And then using a CE grip, we are going to ventilate our patient and making sure that our oxygen is down as well. So we're going to ventilate once every 5 to 8 seconds and checking for chest rise. So I'm going to call that out. Chest rise. Chest rise. And you also want to make sure that there is no gastric inflation. If there is any, generally there is a second user who will do this. As you're ventilating, you'll place your thumb using cricoid pressure on the trachea just to make sure that there's no air going into the esophagus. I'm going to demonstrate how to use suction. First thing we need to do is make sure the patient is in the recovery position like so. So we're going to turn it on just to test the suction. We're going to occlude the pipe and making sure it lights up all the way to 350 milligrams. Yeah, that's cool. If it doesn't, the machine will need to be tested for any damages or leakages. Another way to test suction is by occluding the end of the pipe and testing it on the patient. When suctioning on your patient, only insert the rigid catheter as far as you can see, and suctioning in circular motions for only suction as you're pulling out. Do not suction for more than 10 seconds, making sure the patient can breathe. Complications of using suction is induced vomiting, hypoxia, bradycardia, aspirin, aspirations, laryngospasm and soft tissue trauma. Also make sure not to use the rigid catheter when you're in a moving vehicle. So next up I'm going to take Mel's blood pressure. So first thing we need to do before doing anything is asking for consent. So is it okay if I take your blood pressure today? Sure. Yeah. And is it okay if I just lift up your clothing slightly? Cool. So what we're going to do is we're going to place this high on the arm and making sure the arrow for artery matches up with her brachial artery. I'll just place it up there. And when putting the stethoscope on, you need to put it to the medial of the elbow and making sure you can hear her pulse. Yep, so you can hear her pulse. We'll just make sure the stopper valve is closed so it can pump up effectively. And so making sure we pump it all the way up until we can't hear any heart sounds. And once we do that, we'll just pump up one more and then we'll release and take blood pressure. So Mel's blood pressure was 120/80, which is within the normal range. The normal range for systolic pressure is below 140 and for diastolic it is below 90. If the patient were to be hypertensive, that would be higher than those figures, which can indicate an abnormal cardiac function. Today I'm going to do a respiratory assessment on my patient. First thing you need to do is ask your patient for consent. So is it alright if I can just watch your chest rise and fall?
No worries.
Yeah. So I'm going to do this for 15 seconds and then after that I'll times it by 4 so I can figure out how many breaths she takes per minute. So her breathing was 5, so if I times that by 4 it's 20, so it's within the normal range of 12 to 20. So following on with my respiratory assessment, I'm going to listen to my patient's chest. So is it okay if I can listen to your chest and put the stethoscope down? Yeah.
No worries.
Yeah. So I'm just going to listen for any abnormal sounds such as wheezing, rales, crackling or any stridor. Cool. And just placing it at 2 to 5 seconds for each place. From my auscultations, I was watching my patient's chest rise and falls and also in her abdomen, and I was watching for the volume and the depth of her breathing. So I noticed that she didn't show any abnormal signs such as shallow breathing or breathing too deep, and she wasn't in the tripod position or struggling to breathe. So today I'm going to take Melissa's radial pulse rate. So the normal systolic pressure is 80 millimeters of mercury, and the normal heart rate should be around 60 to 100. So I'm just going to check her pulse rate just to check it is regular and it's strong. If it is regular, if it's not regular and it's not strong, it could indicate some abnormal cardiac function. So is it okay if I can take your radial pulse today?
Yes, sure.
Yep. So I'm just going to take her pulse of 15 seconds. So in the 15 seconds of taking her radial pulse, it was 18 beats per minute. So you times this by 4 to work out 1 minute, so that would be 72. So it was in the normal range and I found that it was regular and bounding. So next up I'm going to demonstrate some fracture management. So our patient here has got a tibia fracture. So first thing we need to do is ask the patient for consent in a real life situation if they can respond. And you just need to let them know that you're going to be touching their legs and feet and if that's okay with them. So we're going to expose both legs just for comparison, and then we'll ask the patient any history, so how did the injury happen, and we'll use the acronym PLUS discs to assess our patient and the injury. So we're just going to assess them, check that they can wiggle their toes, check for any abnormalities of any movement, any swelling, deformities, irregularities, any shortening and any crepitus that will be felt on palpation. And just to be aware that with this kind of fracture, our patient
patient could go into shock. So next I'm going to assess the cardiovascular and neurological integrity. So I'm just going to feel the backs of their feet, just rubbing them and see if they can feel the sensation. And you want to check the temperature on both the legs just to check that they're both the same, so there is blood running to it. And you also want to check the capillary refill on both sides and check that it is less than 4 seconds. And you want to ask what their pain scale is to determine which kind of drugs you're going to administer. So my patient is in 7 out of 10 pain, so I decided that methoxyfluorine is the right drug to use. It's quite good because it's used for moderate to severe pain. It has a rapid onset of about 2 to 5 minutes, and it is self-administered so the patient can control their own pain relief. So you need to, there's specific contraindications, so you need to ask the patient any questions such as if they have any renal impairment, if they have a family history of malignant hypothermia, if they have used it in the past week, and if you need to check if they are unable to obey commands. So in a real life situation, your patient needs to be alert and have said no to all of the above questions. And so when you're about to administer it, you need to just alert them of the side effects. So there may be some euphoria, lightheadedness, nausea, or feeling drowsy. And we just reassure the patient that it is quite normal and it occurs. So you'll use the 5 rights, so the right drug, the right dose, the right patient, the right route, and the right time, and you'll get your colleague to double check this with you. So you'll hand the patient the whistle, and they can administer it themselves, and they'll take 5 breaths for the drug to kick in. And if it was in an ambulance situation, then they would use a mask as well, just so the drug cannot spread to anyone else. Next step, I'm going to immobilise the fracture. So we need to explain the procedure and ask for consent to our patient. And we also need to take a pain scale after they've had some of their medication, just so you can check if it's gone down decently. So our patient has a pain scale of 3 out of 10, so that's pretty good, so we can now go ahead and immobilise their fracture. So you need to select the right kind of splint. So today we've got a cardboard splint for this fracture. So I'm going to ask my colleague to help immobilise the leg, just so I can slide in the splint. So, and I've just got a towel in my box splint just for support and comfort. Okay, so I'll just get my colleague to lift the patient's leg and I'll slide it over. Yeah. And then we're just going to bandage above and below the fracture. And once you have splinted the fracture correctly, you will need to check again for cardiovascular and neurological deficit. So just checking their temperature on both sides again, and checking they can still feel a sensation, so rubbing their feet, and also the capillary refill again, just checking it's less than 4 seconds. And you'll also want to take a pain scale again, just to check that we are safe for transport. So my patient is still in a 3 out of 10, so that's good for transport. So today I'm going to demonstrate how to use a cervical collar. We will use the Nexus rule, so the National Emergency X-ray Utilisation Study. So indications for using a cervical spine cervical collar would be if the C-spine is tendinous, so we would palpate to feel for the tenderness. The patient needs to be alert, not intoxicated, and have a mental state 5 out of 5. And the patient may have some neurological deficits, so for example any numbness in the fingers or toes, and they need to not have any other distracting injuries. So first thing I'm going to do is explain to my patient that I'm going to fit a cervical collar. So is it okay that I can fit a cervical collar around your neck? It may be a little bit stiff. Yeah, it's fine. Cool. So I'm just going to ask my colleague to stabilise the head, and then so I can measure it. So we're going to measure this by the base of the clavicle to the chin, and that's 4 fingers, and we're going to measure it on the side here, 4 fingers. Yep, so that already fits pretty good. And I'm just going to apply it. And just make sure that I pre-bend it a little bit, just so it's not so stiff. So that's pretty secure. So I'm going to demonstrate how to control hemorrhage and bleeding. So first thing we need to do is expose the wound, so just over here, and we need to clean it with some saline dressing, so just make sure all the bacteria is washed away. And then what we're going to do is get our dressing and we're going to fold it as tight as possible for maximum pressure. So we'll just place that over there like so, and then we're going to bandage it up. So making sure we're going in a figure of 8, just so we can maximise the surface area. And also another thing we can do to maximise the pressure is tighten it as we go over, just over the wound like so. For smaller wounds we would only need to use an adhesive dressing, but this is what we'll do for a larger wound. So if the bleeding continues, you'll need to apply a second dressing, and also another way we can do to arrest the bleeding is using elevation and also indirect pressure, so maybe underneath the arm to help stop the bleeding. And once you've bandaged your patient, you need to check the capillary recall and check if it's less than 4 seconds. So next up I'm going to demonstrate how to control a catastrophic hemorrhage. So we need to apply a tourniquet, approximately 10 centimetres proximal to the wound. Like so, make sure it's tight for maximum pressure. And I'm going to tighten the windlass until the bleeding has arrested or there is no distress loss found. And place it in there. And then you're going to document the time, just so other health professionals know when to release the pressure. And also, if the bleeding has not arrested, you can apply another tourniquet above the current tourniquet. And if it was a sucking chest wound, what you can do is apply a deeper pad just to cover the whole area. And if it was an abdominal laceration, what you can do is apply a cling film wrap around the wound just to make sure these structures will be held in place. If you can't access any higher to the wound, you can just apply indirect pressure, so in this case it would be underneath the armpit. Hello, St. John! Okay, just want to check for the dangers, if you can look here and smell anything. Hello sir, can you hear me? There's no response. I'm just going to check the airway for any obstructions, and I'm also going to look and listen for any breathing. So a patient is not breathing, he looks quite grey and pale. Can you please start compressions? AUT under control. Patients are 49, reducing now 15. So I'm just going to set up the AED. I'm just going to place this chest and the other one over here. I'll turn on the AED.
Analyzing heart rhythm. Do not touch
So
the
just
patient.
everyone staying clear of the patient.
Shock advised. Charging. Stay
Make sure
clear
everyone
of
stands
the
clear.
patient. Deliver shock cuff delivered.
And start.
4. Stop CPR.
So I'm just going to get into some airway management into my patient. Insert an OPA. So that is mast seal, obesity or obstruction, age, no teeth, and also sniffs or any snuffles or snort. Chest rise, chest rise. And for good compressions, you need to make sure that you're going into a third chest step. And now's a good time to check any patient history, so you can ask anyone around if they had seen anything that happened prior to this event. Chest rise, chest rise.
Stop CPR.
Okay, we're just going to change over.
Analyzing heart rhythm. Stay clear of the patient. Analyzing heart rhythm. No shock advice. Pause. If needed, start CPR.
So, I can't remember what I was going to say. Okay, we're going to start that one again. Hold on, you put it on way too fucking tight.
SpO2 probe.
What else am I saying?
I don't know.
Blood pressure, bloody hell! 12 ECG cables and a plastic bag with GTN, a razor, and